all. We will start the session now. Before starting the session, I would like to introduce our moderator for today, Dr. Abhijith sir. Sir is working as associate professor and HOD in Abid group of eye hospital. Sir is expertise in specialty contact lens and myopia control. Sir is a member of Serial Lens Society SLC, and he is the only member from Kerala in International Association of Myopia Control. We are honored to have him with us today. Sir.
So thank you so much.
Thank you so much
for joining.
Yeah.
So today our topic is Keratoconus, and our presenter will be Manasika from Optom first year student. It's over to you, Manasika. You can start presenting.
Good afternoon, one and all present here. Good afternoon, ma'am. Good afternoon, sir.
Good afternoon, Manasika. All the best.
Today I'm going to talk about the keratoconus and managed with the deep anterior lamellar keratoplasty. And before that, I'm going to introduce myself. I'm Manasika. I'm doing master's first year in Dr. Agarwal's Institute of Optometry. Now let's go into the case. Keratoconus managed with deep anterior lamellar keratoplasty. And the introduction about keratoconus. Keratoconus is a progressive non-inflammatory ectatic corneal disorder, leads to progressive myopia, irregular astigmatism and visual impairment, and management ranges from spectacle and contact lens to surgical intervention. Now the patient details. The patient age is 28 years and he is male. His occupation is not specified, and he came up with the complaints of blurring of vision in both eyes for about 10 years and more severe visual impairment in right eye than compared to left eye. And the past history of patient, he came up with the ocular history, known case of bilateral keratoconus, and no history of systemic illness like diabetes mellitus, hypertension, thyroid disease, and seizure disorder, and no family history of keratoconus, and the patient is not aware of any drug allergy. And his visual acuity, uncorrected visual acuity in OD is counting fingers close to the face, and OS is 460. Objective refraction through AR is error because of the steep keratoconus, and subjective refraction in OD is counting fingers close to the face, and near vision is less than N36. In OS, minus 10 diopter spherical with minus 6 diopter cylindrical with with 70 axis, and with this correction he is able to read 6/9 and near vision is N8. And H-Beck test is orthophoria, and his pupil reaction is normal. No RAPD is recorded. Extraocular motility is full free, painless in all cases for you. Intraocular pressure, Myers not clear because of the steep keratoconus. Slit lamp examination, cornea features cornea features suggestive of keratoconus. Work striae and Fisher's ring is appear. Anterior chamber depth in Vannery grading number is 3. Lens is clear. And here is the fundus examination of the patient. Fundus is within normal limit, media is clear, vessels are normal, and the optic disc is also normal, 0.3 cup disc ratio, macular foveal reflex is present. And here is the pentacam report of the patient, refractive map, and the first here can you see the keratoconus readings. His keratoconus value is 93.6 diopter in OD, and the thinnest local, the cornea thickness is 122 mu-meter. This is a left eye pentacam report. Keratoconus is 79.5 diopters, and the thinnest local is 332 mu-meter. Right eye central cornea steepening, in left eye asymmetric inferior steepening, and the impression is bilateral keratoconus. It is advanced in OD than compared to OS. Clinical diagnosis, right eye diagnosed with advanced keratoconus with poor visual potential and refraction. In OS, moderate to advanced keratoconus with good best corrected visual acuity. Surgical plan for OD is DALK. deep anterior lamellar keratoplasty. And the left eye is CARS plus corneal collagen cross-linking. This is planned later. The decision, first they'll proceed with right eye surgery. And the second visit procedure is done, DALK procedure is done in right eye. After post-operative first day findings of visual acuity is OD visual acuity is 3 by 60, and with pinhole it is improving up to 6 by 60. In OAS 4 by 60. Keratometry readings in OD, horizontal readings is 44.50 at 180 degree. In vertical readings 51.75 at 90 degrees. OAS readings is error only. Objective refraction after surgery is in OD -6 dioptric spherical with -5.5 cylindrical at 180 axis. In OAS -10 dioptric spherical with -6 dioptric cylindrical with 70 axis. Subjective refraction OD -6 dioptric spherical with -5.5 cylindrical at 180 axis is improving 660, and the near vision is N24 with strain. OAS -10 dioptric spherical with -6 dioptric cylindrical 70 axis is improving 69 with N8 near vision. After a surgery is Hirschberg test is orthophoria, and his pupil reaction is normal, no RAPD. Extraocular motility is full free, painless in all cases. 1 month follow-up visual acuity. Now visual acuity is improving drastically from 660 to 618 partially, and the near vision is from N24 to N8. OS is 560 to 618 partial with the pinhole, and the near vision is N12. In right eye, final diagnosis, right eye status post-DALK for advanced keratoconus, left eye is advanced keratoconus. Further management plan is patient is not willing for left eye surgery at present. So the other option is RGB contact lens trial in left eye. Advised regular follow-up and counseling regarding progress. Contact lens rehabilitation left eye. Decision taken for RGB rigid gas permeable contact lens. Trial conducted after stabilization and counseling. Our aim is visual rehabilitation and the delay of surgical intervention. RGB contact lens trial and the outcome and the result of this in left eye with RGB contact lens, patient distance visual acuity is 6.6 and near visual acuity is N6, and it is improving. Excellent lens fitting and patient comfort. No immediate complications is observed. And this is a overview of the previous slides. Day 1 in OD, distance visual acuity is counting fingers close to the face, and near visual acuity is not near visual. He is not able to read the near vision. In OS, 6.9 distance visual acuity is 6.9, and the near visual acuity is N8 with spectacles. Last follow-up for ODs, vision is improving up to 618 unaided, and the near vision is N8. Mode of correction is post-DALK surgery. OAS with 6.6 for distance vision, N6 for near vision with RGB contact lenses. And the final diagnosis for right eye, status post DALK stable graft improving vision. For left eye, advanced keratoconus will be there. Successfully rehabilitated with RGB contact lens. And discussion, DALK offers excellent anatomical outcomes in advanced keratoconus. RGB lenses remain the gold standard for visual rehabilitation. Surgery can be safely deferred in selected cases with good lens tolerance. Combined surgical and non-surgical approach maximize the visual outcomes. And learning points from this cases, keratoconus management requires stage-based individualized treatment. DALK preserves endothelium and minimizes rejection risk. RGB lenses can achieve near normal vision even in advanced cases. Patient preference and compliance are critical in treatment planning. And the conclusion, This case demonstrates successful multimodal management of bilateral keratoconus. In right eye, surgical stabilization and visual improvement with a talc. In left eye, excellent visual rehabilitation with RGB lenses for distance 6 with near N6. Highlights importance of personalized and patient-centered care. Thank you, ma'am. Thank you, sir.
Thank you, Manasika, for your presentation. So now we have our moderator today who has years of experience and is an excellent speaker. And if you want to learn about keratoconus, if you want to learn about treatment for the keratoconus, there are a lot of options like rose K and scleral lenses and everything. And he is the best person who will be able to explain it that anyone will be able to understand it and you will never forget what he explained. So it's a really an honor and privilege for us to have Dr. Abhijith with us. So over to Dr. Abhijith. You can stop your screen share, Manasika. Thank you so much.
Okay, thank you.
Yes, ma'am. Thank you so much for the invite. That's why I was just going through my slides because we just got the logistics and all these things done like in the last minute.
Okay.
So thank you so much for the invite. And as we had a discussion, this is a new group of people.
That's
So I will just start with the basics and hope
Sure.
that I will get the same group of people within like 2 to 3 months, and I can go for the higher order operation and all the corrections.
Sure. Yeah.
Yes. Okay, so I'll just try to share my screen from my other device.
Go ahead. Yeah, thank you.
Yes. Okay. Yes. So I just want one more thing. We just discussed about DALC. It is a surgical intervention.
Yes.
And we have seen the improvement with dark in one eye. But the other eye, while Manasika was explaining, it was said that the patient is having a good vision with glasses. But we have to keep in mind it is a -10 diopter and -6 diopter cylinder. So even 1 degree rotation will be huge difference for the patient. And that -10 will also cause we shouldn't we are also always considered vision as the how much Snellen they can read. So we are not considering all the other aspects of vision. So
That's right.
in my opinion, that other eye should have been gone for contact lenses at least. Yeah. So I will just start my session. So my session is on enhancing your vision with water. So you'll get an idea why I made the slide, I mean, the session this name. So any of you guys can say, have you seen this image before?
No, sir. This is
First time seeing. Okay. Yes. So I will show you who made this image. That image is actually the first text that explained about contact lenses or something that can enhance vision with water. So the person who made that also made this. Do you know who made this painting? Do you know which painting this is?
You can unmute and tell, or you can post in the chat box. This is a very famous painting, so everyone should be able to
Mona
come
Lisa
up with the
painting.
answers.
Yeah. Yes, correct answer. Yes, Manasika. It is Mona Lisa. So who painted this? It was painted by Leonardo da Vinci. He was a huge, very famous scientist at that time. He made so many things. And in our textbook also, when we are discussing about contact lenses, we can see that his name comes first because he tried an experiment where he dipped his head inside water and he was able to see clearly. He might be having keratoconus at that time. It might not have been diagnosed. Okay. So when a normal person dips their head inside water, or if we jump inside a pool, what will happen? Will we be able to see clearly underwater?
Not clearly, sir, but somehow we can see.
So yes.
Sometime.
So what is happening with that clarity? Okay. So, another thing, if you want to see clearly underwater, okay, let's see. So what is happening? Actually, why we are not able to see clearly? So the explanation is, so we know the refractive index of air is 1. Okay. Can you tell me what is the refractive index of this thing? Our cornea? Anyone? Air is 1. Got it. Then what about refractive index of cornea? Okay. So you should be knowing it is 1.376. Okay. And so what happens is that when the light coming from air, refractive index 1, and it is going to the cornea that is having refractive index 1.3. What is the change? How much change? Basic maths.
0.37.
No, 0.37. Let's round it up. Let's round it up to 0.4. Is it okay? This is we can go with that, right? 0.4. 0.4 change is there. Okay. Now tell me what is the refractive index of water? Can anyone say? Air it is 1. Refractive index of water will be how much?
1.3.
1.33. Yes. It is the same refractive index as aqueous humor, aqueous and vitreous humor. Okay. So if light rays are coming from 1.3 to 1.37, how much difference is it making?
0.3.
No, 0.04.
0.
Okay. It makes 0.04 difference. So the point I'm trying to make is that when air to cornea, the bending is 0.4. From water to cornea, the bending is 0.04. That is, if this is 100% bending, this is only a 10% bending. Right? You got the point? So now let's say the diopters of the cornea. What is the normal diopter of cornea? It is we are saying 43 diopters. Okay. So when we dip it inside the water, it will become 4.3 diopters. That is 10% of that. Because the bending is less. You got the point?
So that is why
I'm audible, right? I just had a call right now. Am I audible? I think so. Hello?
Yes, sir.
Yes, you're audible.
Okay. So okay, so the normally from air to if the eye is in the air, the dioptric value will be 43, and if we dip our eye into water, it will become to 4.3 diopters. So our eye's total power will be gone, like 90% of the power will be gone. Okay, that is why our eye will become very hypermetropic. Okay, so that is why we are not able to see underwater. Okay, now how can we see underwater? One method is to put underwater goggles on. Okay. So how does that help? So what happens here is, so 1.33 water, it goes to goggles. Inside goggles, is the goggle, will the goggles be filled with water? Yes or no?
no, sir.
No. So the goggles will be filled with air. So refractive index will be 1. Okay, then it goes to cornea, 1.37. So the refractive change is maintained here. If there is a pocket of air in between. If you don't have goggles, you can use this technique. So what this person is doing is that he is blowing air inside water and trapping it in his hand. Here he's blowing and trapping the air inside this thing inside his hand. So what happens? Same thing from water to air to cornea. Okay, so the refractive index and refractive changes are maintained, and he is able to see. Okay, so the main thing is that goggles is not just a goggles, it is a refractive lens also. The swimming goggles is also acting as a refractive lens also. Okay, now let's talk about keratoconus, the topic that we were discussing, is keratoconus. So this is the image that we see in textbook when we say about keratoconus. So keratoconus we will say it is conical shape of cornea or change of the shape of cornea. Mainly, it means for me it means it is the cornea is becoming highly irregular. Okay, and due to some reasons and that we will discuss later. Okay, so is this cornea highly irregular? That is this is the question. That the textbook thing, the textbook image of the cornea, is it irregular? How many curvatures can you see in this? Okay, so you will get the point. So yes, now I will just, this is a small experiment. This is a normal lens. This we call it as plano convex lens, right? Plano here, this area plano, in the first it is plano, then it is convex lens. So how will you neutralize this to make it plain? How will you neutralize? This is plano convex. So how will you neutralize?
With concave lens.
With plano concave lens. If we add these together, we'll get a plane lens. Okay? Yes. So this is actually what irregular cornea looks like. Okay. Can you tell me how many curvatures that are there here? So I will just count. There is a concave curvature here, convex curvature here, concave here, convex here, concave here, convex here, concave here, convex here, concave here, concave here, convex here, concave here, and convex here. So how much? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. 13 curvatures are there. Okay. So as far as now, we can only correct two curvatures. That is either vertical or horizontal or in between or oblique astigmatus or whatever. We can only correct two curvatures of the cornea or lens, whatever. Okay. In spectacles. So let's say we correct these two powers. Then 2 will be corrected, 11 curvatures will remain. So how will we correct this? Are there any options to correct this?
Contact lenses.
So how does contact lens help in correcting this? Okay, so simply without contact lens itself, what we have to correct is that we have to make, so this is the cornea with 13 curvatures. We just counted that. So we need to make a negative of that. Just like we neutralized convex with concave, we need to make a negative of that. So 13 negative things. So whatever the curvature was here, we made a 13 opposite curvature of that. And this opposite curvature will make it plane. So because, I will show you. So this is a plane. So all this will neutralize all this and make this refracting surface this plane surface. So we need a convex surface. So we need to add one more step, that is to add a convexity at this front surface. Okay. Now what have we done? We have eliminated all with the negative curvatures over here, and we made a positive curvature which will act as a high plus power like our cornea. So we need to make a lens like this. So how to make a lens? So first, the complicated method I'm just saying. So first we can make topographic image, very resolve with a very high resolution. We'll make a topographic image, and we'll get a lens. and we will do laser. I mean, we can put lasers on the lens, and with laser cutting, we can make the opposite surface. Okay. So I'm just saying, just imagine this is possible. This is actually done, but the lens will cost around 5 lakhs per eye. So what happens is that we have to make a negative like this. So what will you do? We will take a lens. It is called button, and we can put lasers. We will shine lasers, and it will change to whatever shape you want according to the how laser is happening. Okay. So this is very expensive because we are using high definition topographs, and we are using lasers to print this, and the orientation and all those things will be difficult. So is there any cheaper method? So the cheaper method is water. Okay. So how can we use water? So what we can do is that we can take a big lens. Okay. And we can fill it with water. Then the water will change to the negative shape of the cornea. Okay. So this apple is also having so many shapes, right? So inside this, the apple is having, here it is a convex shape. It is slightly concave over here. It is convex over here. It is slightly concave over here. Convex over here. Okay. But the water is doing the opposite, ulta. Okay. So if this was a refractive medium, this completely will be neutralized by the water. Okay. So just like this cat, water will change into whatever shape the negative shape of the bowl. Okay. Now I will show you a video. This is a short video. It is available online. It is from Silveran Laboratories. They also make the contact lenses. They are one of the best Indian manufacturers. So here, what is this balls called as? Can anyone say what is this balls called as? Okay, it is called Orbis balls. Okay, so there was a toy inside, and we pour balls onto this Orbis balls onto this toy. So why isn't the toy visible right now? Hmm? Can anyone say why isn't the toy visible right now? No one? Okay, so each balls are spheres. Okay, so here also it is having a convex surface. In between, it is having a concave surface and convex, concave. So how many balls are there? That much of surfaces are also there. So we want to neutralize it. How will you neutralize? Same thing. We'll pour water inside. Water will be filling all around. Okay, making concave surface over here, convex surface over here, and concave surface over here, neutralizing the refractive indexes and making the toy clear again. Okay. So that is how lenses, that is specialty lenses, especially clear lenses work. And Rose K and RGP lenses also work in keratoconus. The same way, what happens is that, so as discussed before, this will be the cornea. It is having so many shapes. So if it is let's say if it is RGP, it will be resting on the cornea. So the water filled will be tear. Tear will be coming into the lens, and it will be filled here. And the same thing happens. The tear will be taking the negative spaces and neutralizing the irregular cornea and making this the primary refractive surface, which is a very regular plane, and the patient will be able to see. Okay. If it is clear lens, we don't have that much of tear production. So we'll, because it is a huge lens, so we'll fill saline inside and put it inside the eye. Okay. So same thing, the saline will replace replace the cornea as of refractive index. It will make it negative, and the convex surface will be the primary refractive surface, and it will be the plus, and it will act as a new cornea, and the patient will be able to see. Okay. Now I'll just go through some of my cases. So this is a highly irregular cornea. From this itself, we can see a scar on the patient. And if you look closely, you can see an intact over here, a ring intact ring under what I have drawn. Are you able to see an intact ring? So that is also making the cornea irregular. Okay. So it is a 42-year-old man, uncorrected visual acuity CF 1 meter. There were no improvement with our glasses, and cannot even walk without assistance. He came by holding someone's hand because he didn't have other eye. He was dependent on this eye, even, and this eye only had CF1. He was practically blind at that time. I have fitted a cornea clear lenses and vision improved to 6/9, and now he is able to walk freely. So we are also giving them individuality and freedom with the lenses. Okay. This is this case. This is what I have fitted. It is a beautiful wall. You can see the cornea is very regular and hazy. And the green part is saline, which is, I have put some fluorescent so I can see clearly. So the general rule is the saline at the apex should be half of the cornea. So the white part will be 1, and the green part should be half of that. So it is almost half of that. So I fitted the lenses and it was a very good fit and he was very happy. Okay. And there is a case 2. So the first case was intacts with old Keratoconus who had done intacts, and now it has started scarring and all those things. So the second case, and 57-year-old female patient. Her vision, both eye was Keratoconus, and PMD. So PMD is another irregular cornea disease. So her visual acuity, uncorrected visual acuity was at 3 meters, and there was no improvement with the glasses. This is not a good fit. Why isn't this a good fit? Because it is touching over here. You can see green all around, but this area it is touching. There is no green. That means the lens is touching on the cornea, so it is not a good fit. So in this case, we have to change the lens to a custom design where this area of the lens will be slightly steeper than the other areas. Okay, so custom design will be done for this patient, and fitted the cornea lenses. Vision improved to 6/6 both eyes. And the patient, this is one of my favorite cases because this is the first time I'm also getting experience like this. She had immense joy because she recently welcomed a new beautiful granddaughter. She wasn't able to see her face clearly till now, but with the lenses, with the follow, she was able to clearly see her granddaughter's face. See, so as an optometrist, we are giving them immense joy in life that we are able to do. So hope you also get some good cases like this in the future, and also some great experiences like mine. So if you have any doubts, I'm available through phone, email, whatever, or Gmail, I can connect you to me. So thank you so much for listening.
Thank you so much, Dr. Abhijith. It's a pleasure to have you with us, and it's always a joy to listen from you because you take it from the basics, and I'm sure for the beginners it will be very, very useful. And clearly you have depicted everything. So, children, do you have any doubts? Anyone has any doubts? You can feel free to ask, make use of the opportunities. If you have all understood, you can all give a thumbs up. You can also post in the chat boxes. So sir has given an excellent session on Keratoconus. So you can all post your comments and you can thank sir. And as sir said that you can also reach and ask if you have any future doubts also. Any other queries or doubts anyone has? From the third years, is there any doubts or queries? Nyanambigai?
Perfect.
Make use of the opportunity. If you have any doubts, you can feel free to ask now. So Abhijit, I think you explained it so well that they don't have any doubts. So thank you so much for joining us. Nyanambigai,
Thank you
over to
so
Nyanambigai.
much, ma'am, for the opportunity.
Nyanambigai, can you hear us?
Hello.
Okay.
Hello, ma'am.
Yes, yeah. Is there any doubts from the third years?
No, ma'am.
Oh,
They
okay.
all are clear with what sir have said.
Okay, so everyone are happy to hear from sir and everything is very clearly explained. All right then. Yeah, thank you so much. And I think some college heads have also joined. So they also thank you for explaining everything. So thank you, Dr. Abhijit. Yeah, thank you so much. And as you said, surely
sir.
after a few months, when they've learned a little more about Keratoconus and the treatment options, we will come back to you and you can give an advanced session on Keratoconus also.
Yes,
Thank you
ma'am.
so much for joining us. Thank you everyone for joining. So once more, let's all thank Dr. Abhijit. You can all give a thumbs up or whatever reaction you want to show your thanks to sir. Thank you so much.
Thank you, sir.
Thank you, ma'am.